Hello everybody. Welcome to number 1 Doctor channel. Today video is about acquired heart disease, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine. But please do not forget to like and share our videos and subscribe to our YouTube channel number 1 Doctor. And join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about acquired heart disease. Aortic stenosis produces angina and exertional syncope episodes. There is a harsh mid-systolic heart murmur best heard at the right second intercostal space and along the left sternal border. Start workup with echocardiogram. Surgical valvular replacement is indicated if there is a gradient of more than 50 mm Hg, or at the first indication of congestive heart failure, angina, or syncope. Chronic aortic insufficiency produces wide pulse pressure and a blowing, high-pitched, diastolic heart murmur best heard at the second intercostal space and along the left lower sternal border, with the patient in full expiration. These patients are often followed with medical therapy for many years but should undergo valvular replacement at the first evidence on echocardiogram of beginning left ventricular dilatation. Acute aortic insufficiency because of endocarditis is seen in young drug addicts who suddenly develop congestive heart failure and a new, loud diastolic murmur at the right second intercostal space. Emergency valve replacement and long-term antibiotics are needed. Patients with a prosthetic valve need antibiotic prophylaxis for subacute bacterial endocarditis. Mitral stenosis is caused by rheumatic fever many years before presentation. It produces dyspnea on exertion, orthopnea, paroxysmal nocturnal dyspnea, cough, and hemoptysis. There is a low-pitched, rumbling diastolic apical heart murmur. As it progresses, patients become thin and cachectic and develop atrial fibrillation. Workup starts with echocardiogram. As symptoms become more disabling, mitral valve repair becomes necessary with a surgical commissurotomy or a balloon valvuloplasty. Mitral regurgitation is most commonly caused by valvular prolapse. Patients develop exertional dyspnea, orthopnea, and atrial fibrillation. There is an apical, high-pitched, holosystolic heart murmur that radiates to the axilla and back. Workup and surgical indications are as above, with repair of the valve annuloplasty preferred over prosthetic replacement. Coronary disease can happen to anybody including women, but the typical patient is a middle-aged sedentary man with a family history, a history of smoking, type 2 diabetes, and hypercholesterolemia. Progressive, unstable, disabling angina is the main reason to do cardiac catheterization and evaluate as a potential candidate for revascularization. Intervention is indicated if one or more vessels have 70 or greater stenosis and there is a good distal vessel. Preferably, the patient should still have good ventricular function. You cannot resuscitate dead myocardium. The general rule is the simpler the problem, the more it is amenable to angioplasty and stent, whereas more complex situations do better with surgery. Single vessel disease that is not the left main or the anterior descending is perfect for angioplasty and stent. Triple vessel disease makes multiple coronary bypass using the internal mammary for the most important vessel the best choice. Newer hybrid operating rooms that combine the facilities for heart surgery with the radiological equipment to do angioplasty increase flexibility to tailor the therapy for each specific patient. For example, the surgeons might hook up the internal mammary to the anterior descending, and then the interventional cardiologist might do angioplasty and stents on the other, less critical vessels. Post-op care of heart surgery patients often requires that cardiac output be optimized. If cardiac output is considerably under normal 5 liters min, or a cardiac index of 3, the pulmonary wedge pressure or left atrial pressure, or left end diastolic pressure should be measured. Low numbers 0 to 3 suggest the need for more fluids. High numbers 20 or above suggest ventricular failure. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes, Dr. Atif Ahmed.